morning, everyone. Yeah, as indicated, we are presenting today the findings of the Hepatitis C prevalence survey that was conducted in Rohingya refugee camps in Cox's Bazar, Bangladesh. So a quick revisit of hepatitis C infection. It's an inflammation of the liver caused by hepatitis C virus, which is blood-borne. The main transmission routes are via blood, primarily through unsafe injections or unsafe healthcare practices. While approximately 30% of infections are cleared spontaneously within a few months, the majority will become chronic. And the risk of chronic infection is often underestimated. So in fact, if left untreated, 15 to 30% of chronic infections will lead to severe liver disease. The 2022 WHO estimate was 242,000 hepatitis C related deaths globally, mostly due to cirrhosis and liver cancer. So early diagnosis and treatment are crucial, and as Farah indicated, we have effective treatments available. Direct-acting antivirals, DAAs, with high cure rates, however, limited access to diagnosis and treatment still globally. As Farah indicated, our setting is the world's largest refugee camp in Cox's Bazar, Bangladesh, hosting to date nearly 1 million Rohingya originating from Myanmar, residing in densely crowded camps in Cox's Bazar. These camps were established in late 2017, following a massive assault of Myanmar authorities in Rakhine State, leading to an exodus of more than 700,000 Rohingyas to Bangladesh. There's 3 MSF sections present in the camps. OCP, among other, provides the following services: inpatient care for adults in the only secondary healthcare structure available in the camps, and within 2 PHCs, besides general OPD services, mental health, NCD, and since more recently, hepatitis C care. It was noticed since the beginning that many patients seen by MSF showed symptoms of liver inflammation and decompensation, and many tested hepatitis C antibody positive. With effective treatments available and viral hepatitis on the global agenda, MSF decided to start simplified public health model for treatment of hepatitis C in the camps, adopting a model that was already deployed in Cambodia years before. The simplified case management was based on limited laboratory assessments and fewer obligatory clinical visits, and achieved high cure rates, and the capacity was set at 150 treatment initiations per month. Since the start, it was clear that the demand for hepatitis C care was high in the camps, so at times people were literally queuing up to access services. So there was an urgent need to better understand the actual burden of hepatitis C infection and generate a robust estimate of the number of people requiring diagnosis and treatment. To respond to this need, we conducted a cross-sectional survey targeting adult Rohingya residing in 7 of the 21 camps. Through simple random geospatial sampling, we targeted 680 households and included 1 adult per household randomly selected into the survey. To assess hepatitis C seropositivity, presence of antibody, we conducted a rapid antibody test on the spot. And since antibodies are for life, we need to understand among them who are actively infected, and this was done with an expert hepatitis C viral load test looking for hepatitis C RNA. We also administered a participant questionnaire to explore factors associated with exposure to hepatitis C. The main objective was to assess the prevalence of active infection in the refugee population, and among other, we also looked at the proportion of those undiagnosed and aimed to identify factors associated with hepatitis C exposure. Between May and June last year, we included 641 participants with a median age of 34 years. 66% female, and almost all had arrived during the main influx to the camps in late 2017. I'm showing you here as a first result the estimated hepatitis C seroprevalence antibody carriage, which was a striking 29.7%, 32.8% among female, and 22.1% among male, a significantly higher estimate for female. And you can see that all age groups were affected by hepatitis C exposure, with an increasing trend with older age groups, which was more pronounced among female. Next, I'm showing you here the main measure of interest, the estimated prevalence of active hepatitis C infection, which amounted to 19.6% overall, with 21% among female and 15.8% among male. Here, the difference was not significant. In terms of age groups, the lowest adult age group was the least affected, and the highest active prevalence estimates were achieved for older age group female. Another indicator of interest is the viremic ratio, which is the percent of active infection among seropositive, which was very high in this setting, 66.6%, which is kind of reflecting natural infection, with 30% of the infections clear spontaneously in the absence of treatment. So this indicated a significant gap in hepatitis C treatment coverage in the camp population. This also corresponded to the reports of hepatitis C seropositive participants, where only 38% reported previous diagnosis, and 10% reported previous treatment. We also identified a significant knowledge gap on hepatitis C infection in this setting that was highly affected. So nearly half of participants never heard of hepatitis C before. 65% didn't know that hepatitis C infection can be prevented, and 58% did not know that treatment was available. Among those who had heard about hepatitis C before, a good proportion could identify the main transmission modes, depicted in green. Among this, blood and sharing of razors or sharing of needles and syringes. At the same time, a large proportion also chose transmission modes that are not accurate, shown in red, such as respiratory droplets or food. So this underlines the lack of knowledge for hepatitis C in the camp population. In terms of factors associated with hepatitis C exposure, multivariate regression analysis identified female sex, age groups 25 years and older, reported medical injections, and reported surgical interventions significantly associated with exposure. It should be noticed that many reported having had medical injections in the past, while as only few reported surgery, to put in context the risk factors. So in summary, nearly 1/3 of adults was found exposed to hepatitis C infection. We are looking at a generalized epidemic in this camp population, with about 1 in 5 adults living with active infection. And if we extrapolate our survey estimate to the general overall population in the 21 camps, we can estimate that about 86,000 adults are living with active infection requiring treatment. We also found an indication of very low treatment coverage in the camp population and very limited awareness on hepatitis C infection in this heavily affected population. I'm handing to Farah.
I hope you're listening. Because with this summary, we want to take a short pause and actually go back to you, the audience, and ask a question. Given this summary, in this scenario, what would you recommend for MSF as actions to take? Short pause. We will take one recommendation at least. Nobody? Are you afraid? Yes. I planted this person.
So a test and treat campaign, huge, big test and treat campaign with MSF and other actors as quick as possible.
So, of course, we have to listen to our medical director. Our recommendations, what we call for are, of course, a mass HCV test and treat campaign for the whole camp, for which we need a rapid scale-up of access to test and treatment for the population. But we should not forget, to break the transmission chain, we have to also implement a large-scale prevention and health promotion campaign. But this does not come without challenges. We cannot forget this is a highly stigmatized population. Even to disseminate the study results among the stakeholders, the mission actually had to do a lot of risk analysis. We did not want the data to be politicized against already marginalized population. And with the decreasing interest of the donors for the community, many health issues already remain, which competes with this interest. But we should not forget the cost. A whopping 8.6 million euros are needed for just the test and the treatment if we wanted to do a campaign. Of course, we don't even talk about the HR, but that will be also a huge cost because it should be in a short span of time. But the cost, of course, is not negligible. But if we do not address the situation, as Birgit was saying before, many of the cases will have severe illness, which will strain in time the already overburdened health system in the camp. Way forward, MSF should not be alone in this. This is why we are calling for a multi-partner initiative in the camp. Discussions are currently ongoing. The study results did inspire a lot of actors, so we want to see how it goes. For that, the adoption of MSF's simplified public health model is absolutely necessary because it is a big campaign and it needs to be rapidly done, and that's necessary. And for the long run, we would like integration of hepatitis C in all health centers, the treatment, so that prevention of new cases by breaking the transmission chain happens. We also want to put focused advocacy efforts. We would like to be part of Access Campaign's initiative Time for 5 and call for decrease of also hepatitis C viral load cartridges from 15 euros to 5 euros. And we would like that generic DAA importation is possible for all actors inside the camp for the campaign and in future. That's it from us. Thank you.